Hi guys, welcome back. The next topic we're studying is headache that we have all experienced at some point or other in our life. I'll focus on the subtopics like migraine as well, where there can be associated visual complaints in the form of aura. As you can see in this particular image, the patient is having visual blurring or there would be zigzag lines that might be perceived by the patient. So let's look at the various causes of headache incidence wise. And while I'm going to write them, I would like to highlight that the pain sensitive structure in the brain happens to be the dura mater, which is innervated by the trigeminal nerve, and the nociceptive receptors are the ones that will conduct the pain. When you look at the causes per se, if he just says what is overall the number one cause of headache, your answer would be given as tension headache, but this is obviously a diagnosis of exclusion. In some questions, he slightly changed the language of the question by saying what is the leading cause of primary headache versus leading cause of secondary headache, and then also asked about the least common causes. If he says what is the most common cause of primary headache, your answer would still be given as tension headache. But be very careful, if he says the word secondary headache, then you will change the answer to infection. And by infection, I don't only mean meningitis, encephalitis. It could be simply a sinusitis. It could be a plain upper respiratory tract infection or any fever due to any viral illness, which could contribute to headache developing in a patient. Now I will change the perspective as the examiner did. What he asked was the least common causes for primary and secondary. Basically, he's asking about a table that is given in Harrison where incidence based data is given. If he talks about least common cause of headache, then your answer would be given as cluster headache. I'll be explaining the manifestations of cluster headache, which is characterized by retroorbital pain towards the end of this discussion. But the catchword in the MCQ will be, or the language of the patient will be, that he will say, I feel as if somebody is drilling a hole in my eye with a drill machine. I mean, the pain is going to be so excruciating that the person would be very restless, very anxious, would not be comfortable sitting down. You see, if you're telling a person with migraine to sit down comfortably, patient will say, sir, let me sleep. But a person with cluster headache is going to be so miserable. The pain intensity is going to be 10 on 10 and the person is not going to be able to sleep. The least common cause of secondary headache should be answered as brain tumor. These are some minor aberrations that they introduce in the question, so you need to get this fact right. Tension headache for primary, the least common one is cluster headache. For secondary headache, it is infection and brain tumor respectively. And I usually find people slightly messing them up, so that is why I emphasize that twice. Lots of questions are gonna be gender wise also. You see, when it comes to both men and women, the leading cause of headache will obviously be tension headache. But in lot of questions, you will notice that he will not like that as an answer because that's very straightforward. So, well, the second best answer would be obviously migraine in both the genders. But now is a subtle difference which I want you to remember, that when it comes to male patients, you will also be having a higher propensity for development of cluster headache. It is not that cluster headache cannot occur in a female. I'm just saying gender wise data is fairly skewed when it comes to male patient. So lots of time when the question will begin by describing a male with retroorbital pain and the patient is literally pressing on his eye with his hand and he says, sir, I'm ready to poke, because he's a non-medical, right? He thinks that the pressure in the eyeball is more. So he might even use a pointed object. Look at the extreme pain. He's pressing on the eyeball with a pointed object. He says, sir, I just want to relieve the pressure. And cluster headache is called cluster. Why? Because it usually occurs for only few months of a year. Like if you ask the patient to maintain a pain diary, he will note down the data for only few months in a year. So gender wise, I just wanted you to be sensitized to the fact that cluster headache is relatively more common in male patients. And then in lot of questions, you would also get hint from the location perspective. If he says what is the leading cause of frontal headache, tension headache will obviously rule every time. But then you obviously need to keep in mind that if it's a middle-aged patient, hypertension should be kept. Also, there could be a possibility that this is a school-going child, maybe class 6th, 7th, and the child is myopic. He is not able to see whatever the teacher has written on the board clearly. So refractive errors can also contribute to frontal headache, and therefore the scholastic performance of the child will also become less. At the same time, I also want you to keep a watch on possibility of raised intracranial pressure. You see, with raised SAP, obviously other features would be present like projectile vomiting or altered sensorium, or for that matter of fact, Cushing reflex findings could be present. I would just like to reiterate the fact that normal intracranial pressure is 10 to 20 millimeters of mercury, because lots of time they might measure in different units. In millimeters of mercury, it is 10 to 20. And if the pressure is more than 25 millimeters of mercury for more than 5 minutes, that is when we tend to call it raised intracranial pressure. In contrast, if the question begins by describing occipital headache, then the same sequence is to be followed. First is tension headache prevalence wise. Hypertension is also be to kept in mind, but now a special entry would come in which I would like you to remember. In lot of MCQs of occipital headache, tension headache and hypertension will not be in the options and you will end up answering basilar migraine. Well, what will be given in the question that you will answer it as basilar migraine will be the features of cranial palsy that can occur in these patients. You see the ninth nerve is paralyzed. Then one of the manifestations that will develop will be a nasal twang to the voice of this patient. So the family member is asking that why are you having this peculiar voice per se? Like, I can take the name of this singer, Himesh Reshammiya, right? That nasal twang in the voice that he has when he sings. So similar kind of nasal twang would be present, and his brother or sister of this person is thinking that this person is playing a prank on them. And well, this guy will also be having nasal regurgitation of fluids. Why nasal regurgitation of fluids? Because the soft palate will not be able to function properly. In fact, these patients can also be having other features written like vertigo. So when you start reading a question in which migraine features are obviously given in the form of headache and visual blurring, and over and above this, even features of cranial palsy starts getting incorporated, you have to think in terms of possibility of basilar migraine. And obviously the question will definitely mention about the predominant occipital headache of this patient. Why occipital? Because basilar artery is situated relatively posteriorly. However, the next question is to be listened very carefully. I have a patient who's a senior citizen, is let me say 70 years of age. He's retired from the armed forces, very fit. All his life he's never gone to doctors, and now at 70 years of age also he goes for a regular morning walk. He walks 5-10 kilometer, and today is telling you, sir, when I wake up in the morning or any part of the day, I have a continuous headache on the side of my head. He's placing his hand like this on the side of the head. I'm teaching you important cause of temporal headache. You see, in all other causes, I was saying tension headache is the most common one, but when it comes to the MCQ of temporal headache, especially in geriatric population, you need to keep a watch on a extracranial cause of headache that will be discussed subsequently, that is giant cell arteritis. In this slide, I just wanted to give you an overview as far as the prevalence of various disorders is concerned, and you can notice an interesting fact that tension headache is the answer to a large number of questions, but one where I've highlighted do not answer tension headache is a patient who is senior citizen, is complaining of temporal headache. That would be GCA, giant cell arteritis, also called as temporal arteritis. Well, why is it called giant cell arteritis? Because this condition will be having granulomatous vasculitis, and in the granulomas or associated with granulomas would be even giant cells as well. I will now be explaining a subtopic to you of headache, that is migraine, which can occur with or without aura. In fact, the first time I described the term aura before you was when I was describing the topic of epilepsy, where I highlighted aura present with focal seizures. Let me just remind you what I said for aura with focal seizures. This guy is obviously going to have involuntary movement of his hand or jerky movement only in his fingers. But prior to that episode, he might even be having a peculiar smell of burning of kerosene. You see, kerosene oil, plastic, paint, etc. when they burn, they produce a very acrid smell. So this particular person only is perceiving the smell of kerosene or plastic or burning rubber, for that matter of fact. So when it comes to aura with respect to focal seizures, it is gonna be these smells which are being perceived by the patient. But when it comes to the topic of migraine per se, what I imply by aura is presence of either, a non-medical person will only say this word, blurring of vision. However, if the person is relatively more, I would say, expressive, then he might say the word zigzag lines being perceived by him, or some patients who might actually be internet savvy might even use words like scotoma, which would mean a blind spot. So I highlight the fact that when it comes to migraine with aura in adult patients, it's mainly going to be visual complaints that are going to be perceived by the patient, and this is going to be present right before the attack would start. And it's not a hard and a fast rule that you would always be having aura present in migraine. Lots of time, it may not be present. So let's look at what are the other features that will be described by the patient to you. One of the very characteristic features would be the pulsatile nature of the headache. The patient will either use the word throbbing or will say pulsatile headache, which definitely gives credibility to the diagnosis. And this is going to be recurrent episodes. Along with this, there can be photophobia, there can be phonophobia. Like if, let me say, the patient is living in a small apartment with other family members and there's a cricket match going on, India-Australia match, and the TV is blaring at full volume, then I can say exposure to loud noise and exposure to light will make the patient feel miserable. I mean, you would have seen that patients of migraine, they prefer to switch off all the lights, they prefer to draw all the curtains, make the room relatively dark, take in a painkiller tablet, and then prefer to sleep. And usually the headache disappears after a span of about few minutes once the painkiller tablet will start having its effect. And once the patient will wake up, he will feel relatively fresh. But in this case, I'm describing, let me say, a young female. She's having not one but recurrent episodes of throbbing headaches. Like every time she is stressed out, like for example, she had to go to her college and she missed the bus and she had to stand in the sun for long duration, or for that matter of fact, she missed her breakfast. So minor stressors on daily life, like missing a breakfast, standing in the sunlight for long duration, excessive physical exertion, can trigger an attack of migraine, especially in young females. And there could be associated features like photophobia, phonophobia present. In fact, there's also a possibility that this patient was feeling pukish in the morning. Her mother had cooked a favorite dish or favorite breakfast item for this person, but this person says, I felt very bad, but I did not feel like eating food. Even the sight of food, even the smell of food might actually be making this patient feel relatively pukish. The duration of an attack of migraine can be as small as 4 hours. In some cases, the attacks might go off for as long as 72 hours. Please appreciate that the average duration of attack of migraine is approximately 24. Lower limit is 4 hours, upper limit is 72 hours. I'll also describe a condition where attack duration is more than 72 hours. That is called as status migrainosus. So we will discuss the treatment of status migrainosus also. But at the moment, the main objective is to sensitize you to the fact that it would be a one-day illness occurring in a patient. Now, because the attacks are recurrent, let me say the mother of this young girl said, why don't you go and see a doctor? Every time you are, not feeling well and you are missing college, your attendance is going down. So let's go and show to a doctor. Now, this young lady, she says, no, I want to take a painkiller tablet. Let me sleep. When I wake up, I'll feel fresh. After that, I'll go and see a doctor. So this can contribute to friction between, let me say, the parents and the person who's suffering from migraine attacks on a recurrent basis, that when you have this headache, why don't you want to show the doctor? Let us now see what the patient says. She says that when I move my head, like I'm moving my head at the moment, she says, when I move my head like this, I feel as if my head will explode. You see, neck movements will worsen the headache episodes during an attack of migraine. The head feels so heavy in these patients that these patients will avoid movement. Now, even if the family member says, okay, let's book an Uber or a Ola, let's get a taxi, the patient, when he or she is going in a taxi, and suppose the taxi is going over a bumpy road, so every time the taxi will hit a bump, the patient will say, I feel as if my head will explode. Or for that matter of fact, like, the driver brakes hard, so every time there's a jerky movement, again the patient will say, I feel as if my head will explode. What I'm trying to sensitize you to the fact that patients with migraine, they will feel so much of heaviness in their head that they will try to limit their neck movements per se, and that is one of the important diagnostic criteria, that the severity of headache per se tends to increase whenever there's going to be a physical neck movement. It could be sudden braking in the car, it could be a car going over a bump or over a taxi or over a speed breaker, resulting in these patients literally shouting out loud that just let me be alone, I just need a painkiller, and once I'm fine, I'll talk nice to you. And in these patients, even during the attack, if you are trying to talk to the patient, though the patient respects you as a doctor, lots of time be ready for getting rude responses from the patient because he or she is not well. Yeah, later on the same person will apologize, but they'll say to you, sir, I was not feeling well, so maybe I shouted at you on the phone and my mother was asking me to speak to the doctor. But then subsequently, the patient will be respectful to you, and that's one of the important features that you actually need to remember. So let me just summarize what I said. You see, most of the time in clinical practice, we can use this mnemonic by the name of POUND, which is very good way to crack this question, as well as obviously, diagnose the patient clinically. So though the features have already been explained to you, let me just reiterate them once again to you. The nature of headache in migraine is gonna be pulsatile headache / throbbing headache, whereas I've already told you that the worst headache of my life, thunderclap headache, is a feature of subarachnoid hemorrhage. Alphabet O stands for what I highlighted earlier. It's usually gonna be a one-day illness, and then patient is gonna be fine when he or she wakes up. The person will be able to carry on with his routine tasks. Alphabet U would stand for unilateral. Make no mistake, migraine can even be bilateral, but unilateral gives more credibility to the diagnosis. Alphabet N would stand for nausea. Now, I'm not saying that all patients will be having nausea, but yeah, bit component nausea can be present to the sight or smell and food. And then comes alphabet D, which is one of the most important features that I want you to remember. The headache is gonna be disabling in character. So this person, let me say a young male or a female, decided not to go to college, and because this is gonna happen quite frequently, the attendance might actually fall short, or they might have academic problems because they're sick for most part of the week, or let me say 2 days a week the person is not going to college, missing classes. So obviously the academic performance can be hampered because they are missing out the important practical part, or they're missing out, let me say if it's a doctor, the patient might be missing the ward postings. The word is disabling in character, and this also will be deciding, I mean this point that I'm saying, not disabling in character per se, this will also decide the need for prophylaxis. Because if professionally the person is getting hampered, interpersonal relations are getting hampered, in those circumstances you will have to start prophylaxis in these patients so that the frequency of episodes definitely reduces. Out of the 5 features that I have just taught you, if 4 out of 5 features are present and there are more than 5 attacks in 1 year, it means that you are dealing with a routine case of migraine. I shall now be explaining to you regarding a table that is given in Harrison for diagnosing migraine. This is as per the International Headache Society. It's saying almost the same clinical features, but I just want to highlight the way it is given in Harrison. Though for MCQs, pound is more than sufficient for diagnosis. It is just my job to explain to you what is given in the textbook also. So just look at the features that I explained from the International Headache Society perspective or Harrison's perspective. It's going to be unilateral headache, it's going to be throbbing headache, it's going to be increased with physical movement. Please don't be bothered by the fact that I'm repeating the same fact again, guys. In Harrison, it is given in a slightly different fashion. So I just wanted to highlight that there are 3 important features which are to be remembered for the characteristic of headache. Along with this, the patient might have nausea/vomiting. There can be photophobia, that is aversion to light. There would be aversion to talking to family members. What he's saying is that for diagnosis of migraine per se, you can be having any 2 of the features that I've highlighted here, unilateral throbbing and increased on physical movement, and any one from one on the right hand side, and you can make a diagnosis. Why I highlighted that is previously I said at least 4 out of 5 should be present, but here you can see that even 3 features present. So the point I'm trying to make is that lots of cases nausea may not be present, vomiting may not be present. You would have seen so many cases of headache per se who do not have any nausea and vomiting as well. So this is how it is described in Harrison, and it's important that we should be having the textbook orientation as well. This is called as IHS, International Headache Society definition. Now the question that I put up before you was that what is going to be the treatment of a patient who will be having headache persisting for as long as 72 hours and beyond it? I mean, the patient is literally freaking out. He or she is saying, sir, I have been going to different doctors. Like first day when I was having this migraine headache, I went to my routine general physician. He gave me a painkiller. When I took the painkiller tablet, yeah, the headache became a little lesser. I maybe slept for 1 or 2 hours or maybe a little longer. But when I woke up, the headache was still again, or it came back, or it was still very much there. So next day or the same day, I decided to go to some different doctor who then maybe prescribed opioids, maybe tramadol for taking care of the headache component. The patient has taken COX-1 inhibitor, maybe COX-2 inhibitor, patient has taken opioids, but even on the second day, the headache is present. So he or she went to a third doctor who might be even tempted to start triptans in the patient. You have given the standard painkillers, you have used opioids, you have given triptans to the patient, and still the headache is persistent. Even after 3 days, the patient says, sir, I've not eaten well for 3 days. I feel as if my head will explode. Please do something. I want to tell you that status migrainosus is actually a psychotic state. It is a perceived headache on the part of the patient. What I mean by perceived headache on the part of the patient is that in these patients, it is, I would call it like a phantom pain. Like a person had an amputation and still can perceive the pain in the leg. Similarly here, I want to tell you that this is a psychotic state. So you will obviously admit this patient, give a bit of IV fluids, maybe give 10% dextrose to take care of the hypoglycemia component, correct the dehydration part. But the main drug that you will use for a person of status migrainosus, which is a perceived pain status. The patient is perceiving that pain. You see, pain cannot be present after giving opioids, right? You have done everything possible for this person, but still the pain is present. So that's why the question was asked, what is the main treatment for status migrainosus apart from correction of the electrolyte imbalance that can occur because of inadequate eating for previous 3 days, dehydration component coming up, hypoglycemia coming up. Once you corrected that, it would be prochlorperazine that will be useful for these patients. And well, if he says, what will you give to prevent episodes of migraine developing again and again, though the decision for prophylaxis will be based on the history given by the patient of how bad the disease is, the disability experienced by the patient, and I'll also teach you regarding a MIDAS score, which helps you grade the severity of migraine. But if I want to prevent it, I will be using a non-selective beta blocker, propranolol. This would be the first answer in the MCQ, but then you are aware of the fact that propranolol can have its own disadvantages also. It can cause even a deranged lipid profile. It can cause an impaired glucose tolerance test. So in somebody who's having a family history of heart disease, somebody who's having family history of diabetes, I can use a calcium channel blocker also, that is flunarizine. I can obviously use drugs which are used in neuralgia like gabapentin and pregabalin to my advantage. In fact, lots of time combination would be required. The only problem is that more you step up with these drugs that I'm writing before you, the sedation component comes in, the side effect profile also increases. So it has to be a fine balance. It has to be a balance between the prevention of episodes of headache and obviously the sedation component and the other side effects that come. And we might even be tempted to use a drug that we use in diabetic neuropathy sometimes, where there's burning pain in the feet of a person while sleeping at night in diabetes, that is amitriptyline. It is usually single drug that is recommended. Then we can obviously go for polytherapy as well. We can increase the number of drugs required in a stepwise fashion. But in the exam, if they ask you what is the best way for prevention of migraine attacks in a person having severe migraine attacks causing extreme disabling, contributing to decrease in professional competency, decrease in attendance at college or school, then I will be happily prescribing propranolol to the patient. Once we have treated our patient and remembered the diagnostic criteria, the question would come up as, why would you be having attacks of migraine? Well, when the question comes up as why, we need to remember various theories, where I'll first mention the oldest theory, which is based on serotonin, and from that you are obviously able to understand regarding the action of triptans as well. Now listen to my words very carefully when I describe the aspect related to serotonin per se. My message is that there is initially gonna be vasoconstriction of the intracranial blood vessels. The blood vessels that I'm talking about at the moment are like anterior cerebral, middle cerebral, and posterior cerebral artery, intracranial blood vessels. Because of the vasoconstriction of the intracranial blood vessels, there will be a reflex vasodilatation of the extracranial blood vessels. Now, extracranial blood vessels would mean the blood vessels that are coming out of the brain parenchyma and they pierce the dura mater. These blood vessels are coming out of the brain, piercing the dura mater. So when these blood vessels will dilate, they will stretch the dura mater. And innervating the dura mater is the trigeminal nerve. Innervating the dura mater are the nociceptive receptors which are present in the dura mater per se. So every time this blood vessel will dilate, it will stretch these nociceptive receptors, resulting in perception of pain by the patient. And therefore, when we use triptans in these patients, we will be especially acting on these extracranial blood vessels. You see, when you give sumatriptan to a patient, it is a 5-HT1B1D agonist. What that means is that it will neutralize this reflex vasodilation of the extracranial blood vessels. Once it will neutralize this extracranial vasodilation, the stretching of the dura mater will be reduced, the perception of pain by the patient will definitely also come down. This is one of the older theories for why migraine would occur in a patient. When I was a student at your age, I used to study regarding excitatory neurotransmitters causing stimulation of the nociceptive receptors, that is glutamate and aspartate. You very well know GABA is inhibitory, glutamate is excitatory. The latest theory that you will read is with respect to CGRP, that is calcitonin gene related peptide. So this is itself a question that what is the latest theory behind genesis of migraine per se. So he says that calcitonin gene related peptide is the one that irritates the nociceptive receptors of the trigeminal nerve. Earlier, the concepts were related to words like cortical spreading depression. or the words written in MCQ were like vasoconstriction. I can call it vascular approach, or vascular theory, vasoconstriction of intracranial and vasodilation of extracranial blood vessels, and extracranial are the ones which are piercing by the dura mater. So every time they dilate, they stretch the nerve endings per se. So these are the three theories. They have not been till now been able to say with 100% guarantee how much of these contribute to the pathogenesis of the disease, but this is what the experts have been able to elucidate. And our objective is to then understand that once a patient is suffering from this disability, we will be having, or we will be evaluating the patient on the basis of a MIDAS score. What I mean by the word MIDAS score is Migraine Disability Assessment Test, as you can see. And here there is a performa which you can either ask an educated patient to fill up by himself, or you can ask the questions. And I'll just read few of the questions before you. Like the question says, how many days in last 3 months did you miss work, or you missed your school? Or how many days in last 3 months productivity at school was hampered? So depending on the answer, and the patient will have to grade the answers on a rate scale score of 1 to 5. So based on the rating of the patient and the basis of the facts told to you by the patient, that these many leaves per week or these many weeks in last 3 months have been registered in my office, and my office people have told me that we are ready to fire you because you are exceeding your medical leaves, you have taken all kind of leaves that are available according to the rules, have been exceeded by this guy, and they say either you go on half salary or quit the job. And jobs are nowadays anyway scarce. So I mean, this guy is very scared about having loss of economic benefits in the form of the salary that he gets. So my job as a doctor is to actually grade the disability of the patient, in a sense that if the score comes out to be more than 20, if it says 21 and above, it means it's going to be severe disability. And for these patients, the first approach right away will be triptans. I want to highlight this once again. On the basis of MIDAS score, you can start your treatment. If the score is something in the range of, let me say, less than 20 per se, then you can be starting the patient on COX-1 inhibitors like indomethacin, naproxen. If patient cannot tolerate them, you can give COX-2 inhibitors, you can give paracetamol as well. The ability of a doctor to decide whether it is triptans that are required or whether it is going to be COX-1 or COX-2 is not to be based on the personal opinion of the doctor or a bias introduced by the patient. Let's be having a standardization. That was the objective, and that is why they created the score which is called as Migraine Disability Assessment Test, that is MIDAS score, and based on the value you can then start treating the patient. Well, let's just recall what I highlighted. If the score is turning out to be more than 20, I mean more than 20 specifically, if I say more than 21 per se, right, and higher the value, then in those circumstances, he says the first line approach for the patient would be to start the person on triptans. Now, what is the common triptan that would be used? So it will be mostly sumatriptan. And if a person is having nausea, then don't make him take a routine tablet, because he will put the tablet, or he will try to take the tablet with water, might be quicker. Mouth dissolving tablets are very much available. We also have nasal sprays available of triptans, right? Like zolmitriptan is available in form of a nasal spray. Very good results. Within few minutes, the headache will disappear. Then we have subcutaneous injections also available. Auto injectors are available. Patient can keep these auto injectors with himself. Every time the pain episode is unbearable, person can take this injection subcutaneously by himself. Americans are always ahead of us when it comes to technology, so they have also developed transdermal patches of the drug. So obviously that will be a very quick relief obtained in the patient, and it's handy to carry. I mean, you can carry transdermal patch in your wallet as well. Whereas when it comes to sprays, etc., the bottle of glass can actually break, and person might leave behind that in the car or somewhere. So I would suggest, like, if facilities are available, transdermal patch in the wallet will always be handy to terminate a attack every time it's gonna be a severe one. If it is gonna be mild to moderate, that is the values of MIDAS score are less than 20, then first line approach would be to start the person on COX-1 inhibitor like indomethacin. They obviously contribute to substantial amount of gastritis. So concomitantly, you can be giving PPI to the patient, you can be giving antacids, but some people just can't tolerate painkillers routinely. So you can use itorcoxib, that is COX-2 inhibitor. Suppose neither COX-1 or COX-2 can be tolerated by the patient, then you can even use paracetamol. Paracetamol is COX-3 inhibitor. You will be using 1 gram tablet of paracetamol with caffeine. Caffeine anyway, is available in tea and coffee also. So you will notice a lot of people with migraine getting actually relief after taking tea and coffee along with the painkillers as well. The message I want to tell you is that whenever a patient is having severe attacks of migraine, then we can definitely be using triptans, and in some cases it is advisable wherever there is recurrent severe attacks occurring in a patient, rapid progression of the disease is present. I can tell the patient to keep with himself an auto injector in his wallet or maybe in his bag. If it's a she in our lady bag, auto injector of 6 milligram of sumatriptan. You see, you don't need to be a trained doctor or a nurse to give this injection to yourself. It's an auto injector. Now you touch it to the skin, it will inject the drug subcutaneously, and it will obviously cause a very fast relief. While discussing this, he can integrate the aspects with pharmacology also. So a vertical integration here, he might actually have two choices from medicine and two choices from pharmacology. So he might actually talk about longest acting triptan. Well, one of the longest acting triptan that you're aware from pharmacology would be frovatriptan. Why you should know this is because not every attack of migraine will subside within 24 hours. Some can be lasting longer also. No? So if a person is himself telling you that, sir, my attacks usually last for 1 or 2 days, I would be more comfortable giving long acting molecules to the patient. In contrast, I might have a patient who might say, sir, I want a quick relief. Like he's a corporate executive. He has a meeting starting in half an hour. Migraine attack started. He says, boss, do something. I just want to have their international clients coming to me in this corona time from outside, and I have to satisfy them, and I can't just let them go. It's, let me say, a startup. And he says, sir, this is the most important meeting of my life. Then you can prescribe a nasal spray. I had spoken about nasal spray zolmitriptan earlier also. So rizatriptan, zolmitriptan, try it in your patients, guys. The nasal spray is highly efficacious and it will cause a fast relief of manifestations. How do triptans act? Well, you know that from pharmacology. I'm just doing the honors here by mentioning that these would be 5-HT1B 1D agonists. Well, since these molecules will be causing vasoconstriction of the extracranial blood vessels, therefore these blood vessels will also be contraindicated. These drugs would be contraindicated when you cannot use triptans in pregnancy. Like if a lady is having migraine attacks during pregnancy, I will just use COX-3 inhibitors. Similarly, because these drugs would be causing vasoconstriction, you can't prescribe them to somebody who's having a concomitant migraine and prinzmetal angina. Similarly, a patient is having peripheral arterial disease. You see, peripheral arterial disease would be like Burgess disease per se. Then can be basilar migraine. Well, why is it contraindicated to basilar migraine? Is, you see, basilar migraine occurs due to vasoconstriction of the basilar artery per se. That is why cranial palsies will come. No, if you will give a drug that will actually cause vasoconstriction of the already constricted artery, it will worsen the cranial palsy. So the problem with basilar migraine is there is a concomitant cranial palsy, and when you give triptan, then the vasoconstriction of the basilar artery per se can actually worsen the cranial palsy in a patient. Pregnancy, prinzmetal angina, PAD, basilar migraine, most of the time they'll ask basilar migraine. We are contraindications for usage of triptan, and they're obviously to be, or the decision making for whether you should give triptan or not is based on MIDAS score rating. One drug that I have not talked about much but is still mentioned in pharmacology is ergotamine. You can very well understand that ergotamine is safe as long as patient is taking the dosages that you have given. But lots of time, because the headache is very substantial, the patient might actually take 2-3 tablets or even more together, and if ergotamine is taken in excess, then vasoconstriction will also occur in excess, and the excess vasoconstriction can cause digital ulcers. It can contribute to even gangrene possibility. So ergotamine, when I was a student your age, we used to study mainly about ergotamine sublingually for acute attacks of migraine. But as I said, when the headache attack is severe, patient, you told, okay, take 2 tablets or take 3 tablets. Patient might pop in 4 tablets together, or maybe even higher number of tablets, just to get instantaneous relief. And the bad news is the powerful vasoconstrictor effect can actually worsen peripheral arterial disease. It's obviously not going to be given in pregnancy. to the level that it can even cause digital gangrene. So that is why ergotamine can be used, no doubt about it. But then the I would say the safety of this drug as compared to triptans will be on a comparison basis. Triptans are always going to be favored in severe attacks of migraine, and if it is mild to moderate, then routine painkillers will work. Now, based on the clinical history that I given to you for the previous topic, that is migraine, I will be discussing a case-based scenario before you. This is a working woman. She's 25 years of age, and normally she wakes up at like 7:30 in the morning, then gets ready and goes to her work. But today she had to wake up at 5 a.m. She says, I woke up at 5 and this was because of excruciating headache. Like she was maybe holding her head between her hands in your outpatient department or in your casualty, saying that, doctor, I have never experienced a headache so bad as this one. So right in the morning, though I was empty stomach, I took a painkiller tablet, not once but twice over a span of, let me say, 1 to 2 hours. But in spite of taking the painkiller tablet, it's been now 10 a.m. in the morning when she's come to you in your outpatient department or in your emergency room, but the headache of the patient is still persisting, and she says that maybe on the way to the hospital she was also feeling pukish. She thinks that because she has taken painkiller tablets on empty stomach, that is why she's had 2 episodes of vomiting on the way to the hospital. And on listening to her history, initially you thought that maybe she was having drug induced gastritis which resulted in vomiting, but the headache part was so excruciating and was so dramatic in description by the patient that you thought that you should do a more detailed examination. Now, when you did a more detailed examination in the form that you simply asked her that, ma'am, can you flex your neck so that your chin touches your chest, you noticed that she was having a substantial amount of nuchal rigidity, which definitely sent the alarm bells ringing, because traditionally nuchal rigidity is seen with meningitis. So is it a case of meningitis or not is what we need to understand. Well, he did give lots of information in the question with respect to sudden onset headache, followed by vomiting, followed by nuchal rigidity, and then said, what is the probable diagnosis of the patient? My point is that this cannot be called as diagnosis of meningitis, because per se meningitis would always be having presence of fever. So obviously it is not a case of migraine. He will ask you what is the first line differential diagnosis of this patient. Your answer will be subrecurrent hemorrhage. Well, why is there going to be a nuchal rigidity in subrecurrent hemorrhage? Because there's going to be blood in the meninges. Like you are aware, pus in the meninges results in meningeal irritation, and therefore a nuchal rigidity can develop. Similarly, blood in the meninges can also trigger a nuchal rigidity and a Kernick sign and a positive Brudzinski sign in the patient. The way I described it, I hope it's very clear to you that the diagnosis of this patient cannot be migraine, though it is starting with a female, because pound per se is not being satisfied. The diagnosis of this cannot be meningitis, which couple of people casually answered in the exam actually is because meningitis can never be present without any fever. And the fourth differential that was given in the MCQ was intracranial space occupying lesion. So ICSOL per se will have a relatively long history, whereas in this case the history is of few hours. Like she woke up at 5 a.m. today and she is in my casualty at, maybe let me say she's the first patient of mine in the outpatient department or in the casualty department per se. And had this MCQ mentioned the phrase worst headache of my life, had this MCQ mentioned the word thunderclap headache, it would have been definitely very, very easy for you to, come to the final conclusion. But I want to highlight the fact that per se, when you look at these terms, thunderclap headache, worst headache of my life, you are obviously more comfortable with what I've written and read. But the learning point is that if you get a question in which there is information provided for headache per se along with nuchal rigidity, then the combination of the two should definitely alert you to the presence of subrecurrent hemorrhage. I have discussed in the routine lectures of subrecurrent hemorrhage topic per se that one of the important causes of primary subrecurrent hemorrhage happens to be rupture of berry aneurysm, and secondary would come from outside, that would be trauma. But this is a very classical question where on reading the word nuchal rigidity per se, there can be error of judgment and you can answer as meningitis. But as I warned you, you won't fall in the trap of the examiner. Let me give you one more scenario where a young woman, she is maybe she finished her exams and she went out for a movie. And while watching the movie, she's having severe retroorbital pain. She's having watering from one eye. She's having pain from one eye, as a result of which she's feeling extreme discomfort. And then she felt pukish. So she had to leave the movie hall, go into the washroom, and she puked as well. The eye pain became so bad that she actually had to leave the movie hall and come to your clinic per se. And when you examined her, you noticed that she was having a red eye. One eye was grossly red. There was a lot of photophobia associated. There was a lot of ciliary congestion that was associated. Well, you can understand if a patient is, let me say, 50-55 years of age, she's watching a movie, and then there's gonna be a eye pain, a red eye, ciliary congestion, then you have to definitely take into consideration the first differential diagnosis as angle closure glaucoma. Well, why angle closure glaucoma with respect to movie? You see, in a cinema hall, because it is gonna be dark, there's gonna be mydriasis, and you very well know mydriasis per se can result in development of a ciliary block, as a result, once the intraocular pressure will increase dramatically, that is why vomiting will also occur in the patient. So therefore, when you read the question, I am trying to impress upon you the fact that if a question begins by retroorbital pain in a male patient, and well, there is no features like watching a movie, etc., I could have thought in terms of cluster headache also, but in cluster headache, it might have happened earlier also. Acute angle closure glaucoma will usually begin as a severe attack, which is going to cause extreme issues with vision of a person also. So this definitely has to be kept in mind. And cluster headache gender wise is more common in men, whereas glaucoma per se is more common in women. I will also mention regarding what is written as MV, that is migraine variants, and one of the migraine variant that must be kept in mind at the moment while dealing another case is called as ophthalmoplegic migraine. Now, what is the speciality of ophthalmoplegic migraine per se is that obviously in the question he will give you the pound situation, that is pulsating headache, it would be unilateral. The standard features that I've described will already be given in the question, and he might even tell you that these features have resolved after giving triptans to the patient. So the good news is that the pulsating headache is gone, but now a new problem has come up, that is the patient will end up with development of third nerve palsy. Well, the manifestations of ptosis and squint can therefore be described in the question. The speciality, why am I calling it a variant of migraine, is because you see the neurological deficit is occurring post the attack. It is not during the attack of migraine that there is a third nerve palsy developing in a patient. It is towards the end, once there is a clinical resolution occurring with medication, that is where third nerve palsy would occur. So that is why this is called as a variant, because one, you are having a cranial palsy. I mean, every time I've described migraine per se, I have not ever or not even once have I highlighted or talked about any cranial nerve involvement. And here I would say, to add insult to injury, the problem is that the third nerve palsy will definitely recover. It might recover over hours or days, but the point is the deficit will occur after the headache component has resolved in the patient. Let's take one more scenario of migraine variant. This is referred to as retinal migraine. Now, in the current textbooks, retinal migraine per se as a word has been removed from medical literature, but still, I need to discuss it since it is given in the older MCQs. You see, retinal migraine will be having association with shockingly blindness once the pound features will develop. Or for that matter of fact, he may not talk about complete blindness, but he might say that he or she is having some blind spots. It could be single or multiple blind spots in the visual field, that is scintillating scotoma or scotomas. Definitely there will be a gradual resolution as the disease will progress, but again, because there is a dramatic presentation of blindness occurring in a patient, you might even think that the person is having stroke. Another migraine variant which is of interest and is asked by examiner is called as familial hemiplegic migraine. You see, my objective now has been to basically focus on presence of neurological deficits with respect to migraine as well. Like as the name itself suggests, when a person will develop while this person will develop this attack first time, because there is hemiplegia, you will think it is stroke. So you will have to do CT in the patient. You see, during the workup of migraine per se, I never said that you need to do anything. It is a clinical diagnosis. I never said you need to do a CT or a MRI for diagnosis of migraine, but for familial hemiplegic migraine, when the person will present first time to you, you as a doctor will get an impression as if somebody has had stroke, even if it is a young patient. You will have to do neuroimaging in the patient. So the reason why we call it migraine variant is obviously because of the varied manifestations that you will see in the patients, like a third nerve palsy or even a blindness occurring in a patient. But much more important than that, I want to highlight that imaging will be done in migraine variants per se, because you want to rule out possibility of a cerebrovascular accident. Familial hemiplegic migraine is to be remembered because it is called as a calcium channel defect per se. In fact, calcium channel defects are themselves are important MCQ perspective. Why? Because one, I have spoken about calcium channel defect in Lambert-Eaton syndrome, where we have anti-P by Q antibodies affecting neuromuscular junction and less acetylcholine release. Then is gonna be hypokalemic. This is discussed in the channelopathies component. So if you scroll down in fairly in the app in CNS, you will notice channelopathy topic. That is where I've spoken about hypokalemic periodic paralysis. It is of two varieties, type 1 and type 2. It is type 1 that is related to calcium channels. And the third one is obviously what we are discussing at the moment, but I'm just jotting down the name for practice sake, familial hemiplegic migraine. So these are three standard examples of calcium channel defects which are asked in the exam per se from the calcium channel perspective. In contrast, when you talk about episodic ataxia, it would be a potassium channel defect. I shall now be describing another case before you, which is of a patient of geriatric age group. This is a 70-year-old man. He, let me say, has retired from the armed forces and he was having very good physical health per se. And even now he goes for a morning walk on a regular basis, and he says that usually I feel very fit, but for previous couple of weeks I've been running fever, for which I've been taking paracetamol off and on. Fever of unknown origin is the initial presentation of this guy. He might have been worked up for tuberculosis, even for connective tissue disorders, but the results are turning out to be negative. And then he's putting his hands on his temples, like he's rubbing his hand on the side of the head, and he's saying that, doctor, I usually avoid going and seeing a doctor. I have always been very fit all my life, but now I'm having this temporal headache. So since he was pointing like this, I decided to just put my hand and examine the superficial temporal artery of this guy, which is just anterior to the tragus. And to my surprise, I could feel a cord-like structure at the temporomandibular joint. Just anterior to the TM joint was the cord-like structure, the thrombosed superficial temporal artery. What you can understand from my description is that I'm describing a case of a patient who's actually having a granulomatous vasculitis involving the superficial temporal artery. You are aware of the fact that the superficial temporal artery slash auriculotemporal artery is gonna be supplying the scalp, and in this case, because there is narrowing of the artery, so there would be a definitive ischemia of the skin of the scalp. Over and above this, I also want you to remember that this artery supplies the temporomandibular joint. So there is another history that could be given in the question. The same old man not only is complaining of headache, which is extracranial cause of headache that I'm discussing before you, because there is ischemia of the skin of the scalp, there will also be information given about jaw claudication, which is such a very characteristic point that most guys, they say, sir, we don't need to remember anything else. Right from the word jaw claudication, we are able to pick up that this question is dealing with a vasculitis that is called as giant cell arteritis. Giant cell arteritis presents in senior citizens or geriatric population, initially can be misdiagnosed as fever of unknown origin. There are two important pointers towards the presence of giant cell arteritis. One is temporal headache and second is jaw claudication. Now, since I had found this cord-like structure at the TM joint, I decided to do a biopsy of the same as well. In fact, this is itself very characteristic statement, because the way we are trained as doctors in India, every time you feel a cord-like structure anywhere in the body, you think it is a thicker nerve of leprosy. But then I use my common sense that in leprosy, it is the posterior auricular nerve that would be behind the ear, and here the lesion is present anterior to the ear, so it can't be a posterior auricular nerve. This cord-like structure at the temporomandibular joint is the thrombosed superficial temporal artery, and the bad news is that this person can even go blind. I mean, I want to tell you that not only can this disease involve the superficial temporal artery, which is a branch of external carotid, you could even be having internal carotid artery branches getting involved in this case. Well, which artery will get involved? It's the ophthalmic artery, guys. And once that is affected, you could also be reading about monoocular blindness in this previously fit guy. I mean, he is boasting before you that earlier I have been so fit all my life that I never had to go and see a doctor. I never have taken even vitamin tablets. I mean, that's how the patients usually boast before you. I've not even taken paracetamol tablets, but now I'm having to regularly take paracetamol, and now I'm even having visual problems. In the workup of this patient, I decided to do a erythrocyte sedimentation rate, and I was surprised by the report, so I called up the lab. I said, is this report correct? They said, yeah sir, we checked the same sample twice. The ESR of this patient was a shocking 100 millimeter fall in the first hour. Please appreciate the fact that in males the ESR is going to be 0 to 8 millimeter fall. In females, it's 0 to 20 millimeter fall. In tuberculosis, in SLE, in autoimmune disorders, you would have seen ESR of 60, 70, 80 maximum, but ESR of 100 is a grossly elevated value. In fact, medical disorders where ESR can be going up to 100, I'll just jot them here, though there are many important ones are subacute bacterial endocarditis, then is giant cell arteritis, then is multiple myeloma. These three medical disorders should always be considered. And my next statement is very dramatic in a sense that ESR is always considered to be a prognostic feature, no? But ESR as a diagnostic criteria, ESR as a diagnostic criteria is written in literature of giant cell arteritis. Alone ESR is obviously not diagnostic. A combination of jaw claudication, temporal headache with elevated ESR gives more credibility to the diagnosis. I will now be talking about an invasive investigation which a patient might even refuse. That is a vessel wall biopsy, and it might have to be done from multiple places because there might be a segmental involvement of the artery in this case. When you will examine it under microscope, you will be having presence of giant cells. So that is why you call it giant cell arteritis. It is anyway an example of granulomatous vasculitis. The name given giant cell is primarily because of the histopathological correlate. In fact, biopsy can be therapeutic in this condition as well. How therapeutic? When you cut this, when you take a biopsy, no, you're cutting the nerve endings also. So therefore the headache severity might actually decrease post biopsy. For the treatment of this condition, there is no requirement of any triptan because it is a vasculitis. We be using steroids for this case. So I've described, I would say 3 migraine variants, and then I've described 2 cases before you. So I would like to just make you practice these again so that you can get the perspectives because I said a lot of things right away. If a question begins by describing worst headache of my life, thunderclap headache, well, thunderclap headache actually means that the peak onset of headache, like right, if now the headache will begin, the peak can be obtained as early as within 1 minute. Like headache starts right now, after 60 seconds, patient is sitting with his hands holding his head and the patient is even having difficulty in communication. Then I spoke about a couple of migraine variants before you, but I sensitize you to the fact that retroorbital pain in a male should be thought of as cluster headache, but in a female, especially after watching a movie, when in the dark there will be pupillary dilatation, angle closure glaucoma should also be kept in mind. The migraine variants have already been explained well and they are self-explanatory. I mean, if he says familial hemiplegic migraine, it will have hemiplegia. But if we are migrating to a older age group patient who is having fever of unknown origin and extracranial cause of headache, it is giant cell arteritis, which is definitely to be taken into consideration. And now I'll describe a case before you. Instead of straight away saying the answer once again, let me just describe the clinical history. This is a 35-year-old lady. She came to me. I said, okay, ma'am, what is your problem? She tells me, my problem is I have 2 children. And I looked at her. I said, you have 2 children, that's the problem. She says, yeah, doctor, these 2 children, they're very naughty and they keep on, watching television all the time. And though they are obviously small kids going in preschool or school, she says that she's worried about their performance per se. They are having poor school performance. They are addicted to internet. They keep on watching videos on YouTube. And she says that I'm always stressed out about them. I said, okay, fine. I mean, children nowadays are naughty. They're addicted to internet. That is fine. But then what is the issue? She says, doc, along with this, I also feel as if somebody has taken a piece of cloth, tied it around my head and is tightening it. So she's also complaining of band-like compression over her head. And when I say, can you just pinpoint where is the headache intensity more? Instead of describing holocephalic, whole of the head, she's mainly pointing to the forehead and to the occiput. Either of the two, she may say, so doctor, I feel heaviness in the forehead and a little bit of heaviness at the back of the head. So I thought, okay, let me just examine. Maybe she might be having hypertension, but her blood pressure was within normal limits. So I thought maybe she could be having requirement for glasses, and I sent her to the optometrist for refraction testing in my hospital. In the same consultation, I said, okay, in the next room, just get your eyes checked, come back to me. And her visual acuity was also perfectly normal. You can very well understand what am I leading at, but before committing to the diagnosis of tension headache, let the examiner himself rule out common causes like sinusitis, for which the Waters view X-ray paranasal sinuses was turning out to be normal. I wanted to be extra cautious. I wanted to rule out papilledema, so I did a fundus examination also. You can see here the examiner has himself ruled out hypertension, refractory errors, sinusitis, raise ICT for you. So once you are seeing that the examiner himself is ruling out common causes of headache, which are right before you: hypertension, refractive error, sinusitis, raised acidity, that means that you can now comment on the diagnosis of exclusion, that is tension headache. The main crux of this particular slide is to sensitize you to the fact that common causes of headache should be ruled out before we can comment on the diagnosis of the patient as a tension headache per se. Now we will take up another case. This time, instead of straight away giving the history, I will say myself that I'm dealing a case of cluster headache. This is a 25-year-old guy. When he came to my clinic, I was actually attending to a different patient. So I heard this young guy's voice inside my chamber. He was arguing with my receptionist. So because he was talking pretty loud, I just got a little irritated. I went out of my OPD chamber just to confront this guy and said, "Come on, man, why are you shouting?" And this guy, when he looked at me, he was really miserable. He said, "Doctor, I feel as if somebody is drilling a hole in my eye with a drill machine." This guy was complaining of severe retroorbital pain, and in fact, he was using one of his hand to press on his eye, and he was arguing with my receptionist that I want to see the doctor right now. So I told him, "Okay, remove your hand. Let me see your eye." When he removed his hand, his palms were wet with the tears that were coming out of his eyes. Not that this guy was crying, but there was a lot of watering happening from the eye, that is epiphora. And in fact, in these patients, the amount of tearing that occurs in the eye can be so much that actually the tears can travel by the puncta, by the nasolacrimal duct, and open into the nose. So I will also notice that this chap will be having some amount of nasal stuffiness present. Retroorbital pain in a young male, recurrent attacks of it with watering from the eye, nasal stuffiness is definitely a cause of concern. And I also noticed that his eyes were relatively red. There was a ciliary congestion present. There was a bulbar congestion present. So these are the usual details that will make you think in terms of possibility of cluster headache. Cluster headache is called so why? Because these patients would be having, let me say, these attacks for 2 consecutive months, like maybe February, March, then April, May, June, July, they might be asymptomatic, and then again in August and September, again for 4 weeks, that's total of 8 weeks, again the attacks will come. So most of the time the attacks might be occurring for 8 to 10 weeks per year. It's gonna be like 4 to 6 weeks in the starting of the year, 4 to 6 weeks in the later part of the year, or something around about that. So if you ask this guy to maintain a pain diary, you will notice that the attacks will be having a seasonal predilection. Most of the attacks of cluster headache will either be in the spring season, that is about March, April, or it's gonna be in the autumn season, that's gonna be August and September. Though there's not a hard and fast rule that they will begin only in these months of the year, but I basically wanted you to be aware of the fact that why are we calling it cluster? Because the attacks are not gonna be all the year around. Like migraine can occur anytime, but cluster headaches are usually having a predilection to be occurring for only few months in a year, and the number of attacks per day can definitely be recurrent. I mean, this patient can be totally, I would say, incapacitated. He cannot go to his work, he cannot work on a laptop, he cannot maybe listen to music on a mobile phone. The attacks are gonna be as much as 1 to 8 attacks per day. Please appreciate that in migraine it's gonna be 1 attack in a day. It is a 1-day illness, but here 1 to 8 attacks can occur, and they could be like all, instead of being all year around, they could be focused or concentrated in only few months of the year. The attacks of pain are so bad that person cannot sleep. In migraine, the patient will say, "Leave me alone, give me a painkiller tablet, I'm gonna pop it in and I'm gonna switch off all the lights and I'm asleep, and once I wake up, I'm gonna be fresh." In this case, the attacks are gonna be so bad that they're gonna awaken the patient from sleep. I repeat the fact once again. Please appreciate the pain rating here would be 10 on 10. It will awaken the patient from sleep. So that tells you about the intensity of pain present. And you see, tolerance of pain in everybody is different, no? Some of these patients would be actually having psychotic manifestations, guys. We might have to start lithium in these patients. Why lithium? Because they might take a pointed object. See, I'm saying a big thing. He's taking a pointed object and he's hurting his eye. Imagine, he says, "I feel as if the pressure in my eye is increased. If I poke myself with a pointed object, I think the pressure will be released and I will be fine." So you might be having self-mutilation features developing in this. I mean, the intensity of pain in this chap can be so bad that self-mutilation features might actually prompt you to refer this guy to the psychiatrist, and you might have to start lithium in these patients. And if you read the usages of lithium from pharmacology or psychiatry, then the topic that I'm teaching at the moment, cluster headache, is written right at the bottom. Obviously, if they talk talk about maniac depressive psychosis and rapid cycling where they use lithium initially, but cluster headache is also one of the indications. And this patient during the attack, if you offer him a chair, like you say, sir, please sit down, let's talk, he's gonna be having a lot of pain. He said, no, sir, I just can't tolerate the pain. He'll try to move around and he'll be very, very restless. So you have a young individual who's pacing to and fro in the room. He's restless, he's anxious, and he's obviously worried about these attacks, which are even not letting him sleep. This is one of the most excruciating pain syndromes that you will actually encounter in your clinical practice. And once you made a clinical diagnosis of cluster headache on what I have just highlighted, I then want you to remember that the first line management for these patients would be answered as high flow oxygen. Well, how does high flow oxygen work to treat this condition is still an enigma. There are a lot of theories behind it, but the concept is that if you give oxygen at a rate of 12 to 15 liters per minute to these patients, then the severity of pain would definitely decrease, and subsequently you can give these patients sumatriptan. That could be a subcutaneous injection, 6 milligram, and that will definitely cause an improvement in the condition of this patient. And if you want to prevent these attacks from occurring, then the drug that is recommended is not propranolol. That's a slight difference that I want you to remember from migraine. When I was teaching you migraine, I was saying best drug for prophylaxis, propranolol / flunarizine, but now I'm requesting you to remember verapamil. If required, you might even be using topiramate in these patients. Yes, the same drug that you use in patients of epilepsy. And then you will also be using what is called as vagal nerve stimulation. Now, I have taught you about vagal nerve stimulation even in management of refractory epilepsy. If a person is having a medically refractory epilepsy and you use the maximum dosage of drugs, you will go for vagal nerve stimulation. That is an invasive vagal nerve stimulation. Here, the small alphabet N basically means that you are going in for a non-invasive vagal nerve stimulation, which is shown to reduce the frequency and the severity of attacks. I want you to mainly remember non-invasive vagal nerve stimulation is used for, the answer would be the topic that we're studying, that is cluster headache. Additional drugs that may or may not be given for management of this condition can be like melatonin, or another one that can be used is gabapentin or pregabalin. I mean, whenever we are talking about nerve pain per se, neuralgia per se, gabapentin, pregabalin, amitriptyline always come in the discussion. But if they primarily talk about prophylaxis, then the first answer for prophylaxis in this case would be answered by you as verapamil and topiramate. When you compare cluster headache with SUNCT, that is short-lasting unilateral neurology-form headache with conjunctival injection and tearing, the point is that epiphore or watering from the eyes and redness of the eyes can be a feature of both of them. The differentiation can be made by 3 points that I want you to remember. If a question mentions about a person having excruciating pain all through the day with the number of attacks on a regular basis going up to 3 to 200. I mean, just look at the huge amount of disability that I'm talking about. In SUCT, point number 1 to be remembered is the number of attacks is gonna be in hundreds. Second, the duration of attacks is however gonna be in few seconds. You see, let's do a quick recap. When I discussed migraine, I said it is a one-day illness. In cluster headache, I said only for a few months of the year person will have a problem, but it would be 1 to 8 attacks per day. And I want to highlight the fact that when it comes to patients of cluster headache, the duration of pain in this case will be something in the range of 115 minutes to 180 minutes, that is 3 hours. If you recall migraine, I was teaching that the minimum duration of attack of migraine was 4 hours. Here upper limit is 3 hours, and now look at the data, I'm saying only maximum 4 minutes. So this is going to be stinging pain on one side of the face in an individual, or let me say along with association with the conjunctival injection and tearing. And we are going to use a drug that we normally used in cardiology for management of ventricular tachycardia, that is IV lignocaine for this patient. So when you read the broad topic, trigeminal autonomic cephalgias, you will read about terms like cluster headache, especially SUNCT. The differentiation can easily be made on the basis of the frequency that is given in the question. The learning point is migraine is gonna be 1 day illness. When it comes to cluster headache, it's gonna be maximum 3 hours. It's gonna be 1 to 8 attacks per day in few months of the year, and this is gonna be terrible. It's gonna be like stinging pain all through the day, causing inability to do anything. Eating, sleeping, walking, talking, everything is not possible because all he's saying is I suffer from pain all day, and we are using a molecule which is given intravenously at this point of time and is traditionally used in cardiology. So these are the details to be studied for this topic. Keep hammering, guys, keep learning, and I shall see you with a different topic. Thank you so much.